Thank you so much for the great honor to allow me to speak here. It's a real pleasure. The best things come at the end. This is a long week that I had, and this week basically started in Mumbai, went on to Guwahati, and then we were in Meerut, and then Jaipur, and yesterday we were in the city with the airport designation BBI, and Bhubaneswar, yeah, sorry. Sorry for everybody who is from Bhubaneswar. I understand this is also shown on the internet, so welcome everybody online, wherever you are in India, or wherever else in the world you are. I know at least one person from outside of India who is watching this, who is my son, a young doctor in training. And he actually did this also the last 2 times we did this, a year before and before that. And he is my hardest critiker for all of this. Now, really a very interesting topic I hope we can cover here together after this excellent introduction with many new exciting devices, in part there and in part on the horizon. Here's one more thing, as the former Apple boss would have said, and that thing is actually ready for use now. Now, iron deficiency is a big problem. Iron deficiency is one of the important comorbidities you will see in heart failure patients, and we started to really look into this about 15 years ago. There was a growing understanding, and today I believe it is really a commonplace statement, that targeting the comorbidities of patients with heart failure gives a chance to further improve the care of these patients and to really make a difference for survival, for hospitalization rates, but also for symptoms and exercise capacity. Now, one of these comorbidities is renal dysfunction, is the cardiorenal anemia syndrome, is then anemia which is also connected to iron deficiency. When the whole investigation started 15 years ago, it was really all investigated from the perspective of anemia. First investigations included this analysis of the factors leading to anemia in patients with acute heart failure. And iron deficiency was already mentioned there, but if you look at this from today's perspective, it is kind of surprising that the number of patients given there was only 21% with iron deficiency. Now, you need to understand, of course, at the time there was a definition of iron deficiency based on absolute iron deficiency. So this is not all the patients that we know today have a problem with iron deficiency. Indeed, you have to add at least half of the patients that have anemia of chronic illness, and then if you add here the half of these 58% patients, then you would come up with at least 50% in total having iron deficiency. Now, when you then want to develop a treatment for this problem, it is important to understand mode of action, pathophysiology. Hemodilution is, of course, part of the anemia problem, and very often you can simply use diuretics or better general heart failure care for the patients to get rid of some of the problem of hemodilution. Inflammation is an issue, chronic kidney disease is an issue, and at that time iron deficiency came up already as an issue, but was only by a few groups, if at all, investigated. There are really several reasons that can lead to problems of iron uptake, but more about this later. When you discuss the iron metabolism, it's good to understand the basics. Each and every person, us here, our patients, have or should have about 3,000 milligrams of iron in our body. 3,000 milligrams, 3 grams, sounds not very much. The iron metabolism is very tightly regulated. There is a loss of about 1 to 2 milligrams every day, and that loss needs to be recovered, and it is recovered by uptake of iron from nutrition. The uptake of iron from nutrition is maximum 6 milligrams per day. You need to also know that a patient becomes symptomatic when they have at least 1,000 milligrams of deficit of iron. So it's clear, if you look at the loss of 1 to 2 milligram per day, that iron deficits build up over years. But then also, when you think about correcting it by oral iron, with a maximum of 6 milligram to take, correcting iron deficits using oral medication takes 6 months at least. So the first big advantage of the treatment that we are discussing here today, intravenous iron, is that you can solve the problem in a few days or a week. Now, the iron in our bodies is distributed in the blood, in the hemoglobin, in, of course, the liver, but it is also in the skeletal muscle, about 10%. And this is important to remember when you will see some of the effects. Now, why is iron deficiency present in our patients with chronic illness, particularly discussed here heute in heart failure patients? Well, there is basically production of cytokines and other factors in case of inflammation. The liver, for instance, produces hepcidin. Hepcidin is produced in any situation of infection, and hepcidin interacts in two places with the rest of the body, and that is ferroportin in macrophages and it is ferroportin in the gut cells. What is it doing there? Well, ferroportin is a regulator of iron to move from the gut into the body. Ferroportin is really controlling also the movement of iron from macrophages into the rest of the body. And hepcidin can close down this portal pathway, if you like. And the reason for that is that nature invented this system to protect against infection. When you have infection, you have inflammation. So the signal is inflammation. It produces hepcidin, closes down iron, because iron are really is needed for bacteria to grow on. So this is a simple form of an antibiotic. Nature invented iron deficiency to protect against infection. But in chronic illness, where you don't have an acute infection, this is actually counterproductive, but of course nature didn't invent anything against heart failure, because heart failure is late, heart failure is not relevant for reproduction of the species. So when you then look into objective ways of assessing iron deficiency, bone marrow biopsy is the gold standard. If you do this in patients with acute heart failure, you will find more than 70% of patients have iron deficiency by bone marrow biopsy. This is not the gold standard for clinical practice, it's a theoretic gold standard. Clinical practice needs biomarkers. And there is a very simple way of doing this. Absolute iron deficiency can be diagnosed using a ferritin less than 30, and functional iron deficiency can be diagnosed using a ferritin less than 100, or a ferritin less than 300 plus a transferrin saturation of less than 20%. Now, iron deficiency can, in this way, very simply assessed by measuring some blood markers. What is missing, of course, from the iron deficiency definition is hemoglobin. Hemoglobin is reflecting anemia, but it is not reflecting iron deficiency. You have patients that have iron deficiency in the presence of anemia, quite many, but then also patients without anemia. If you look into this in some numbers, the frequency of patients with anemia having iron deficiency in heart failure in Europe is about 60%, 40% for non-anemic patients. But because non-anemic patients are so more prevalent, the absolute number of iron deficiency patients outside of anemia for us is much bigger. Now, on the right-hand side, you see a first hint that iron deficiency is prognostic. Whenever a patient with heart failure is iron deficient, more heart failure hospitalization, more death. Now, the real question is this iron deficiency just a reflection of anemia, or is this independently important? And I would like to document to you that it is independently important. Now, when you look at this here, you see that patients in the second column who have anemia but no iron deficiency, they have a hazard ratio of 0.9. They have no increased risk of death. If patients, however, have iron deficiency, the third column, but no anemia, they already have a doubling of risk, and if they have both together, fourfold increase in risk. So this showed us for the first time in this publication from 2011 that iron deficiency may be the lead cause, and there was a second publication 2 years later that confirmed this in 1,500 patients. When you have anemia but no iron deficiency, there is actually almost no prognostic problem. The problem comes with the presence of iron deficiency. How can this be? Well, you can basically explain this by looking into the pathophysiology of iron deficiency and the relationship to oxygen. When you think about iron and hemoglobin, this is relevant for oxygen delivery, whereas iron in itself is relevant for oxygen utilization. Iron in tissues is responsible in mitochondria for respiratory chain reaction being more efficiently run. It is a catalyst of energy production. So an iron replete tissue has more energy available for performance of cells, of organs, than an iron deficient tissue. Now, is this really relevant for India? Everybody says so, but what about numbers? You will actually not find many publications, unfortunately, and really this is a plea for starting to get this done, that actually documents the number of iron deficiency cases in India itself. Tomorrow there is the Heart Failure Association of India meeting, and we will have a chance to discuss then again how to better have research in the field of heart failure in India. And it would be great if some of you could be interested in putting together data in a registry, or if you have a very big practice or big hospital, just publish your own data. And there are means of doing this now in an easy way, and document how this is a problem for India. But what data is available comes interestingly from Singapore. In Singapore, Carolyn Lam and her group, they did a study looking into the prevalence of iron deficiency in heart failure patients versus controls, and you can see 60% of patients overall had iron deficiency. In anemia, it was only slightly more frequent than in patients without anemia. And then if you look by gender, women a little bit more iron deficient than men, 70 versus 60%. But here's the interesting point. Chinese, 58% in Singapore, then Malay, 63%, and then basically when you have Indian population in Singapore, 82% frequency of iron deficiency. How can it be that Indian population has more iron deficiency than others? Well, there may be a component of genetics, and this could be explored in the future, but this is maybe not everything. One of the problems is tea. A very simple Indian-wide used drink. Tea is blocking iron. When you have tea with your meal, you block, with black tea at least, 80% of the iron in your meal with one single cup of tea. Now, if you have a mint tea or if you have green tea, it's a half or a third of that. But very often for this kind of tea, you have then more tea instead of just 1 cup. So blocking the iron is done by chelation of the iron. So it is then impossible for the body to take up this iron that was in the food. What is the solution? Well, there are several plans we can develop. The first plan is we could say Indian patients with heart failure should no longer drink tea. I think that's not possible. I think doctors are not there to make patients unhappy. Doctors are there to make it possible for them to have a happy life. So maybe this is not a solution. Second solution, well, ask them to drink the tea at least 1 hour different from the nutrition. This may be possible for some people. I'm not sure it's a global solution to the problem, but it may be some solution. And of course, you may also consider treating the iron deficiency in an effective way and then this problem becomes nullified. The second issue is that many people think that vegetarian food, and more than 50% of Indian population are vegetarian, that vegetarian food contains less iron. I don't want to ask who believes that. It's many. But that belief is actually not really correct. Here I give you some numbers for the iron content of meats. And as you can see, the numbers range between 1 and 6 milligram per 100 gram of food. And here are the numbers for the food that is basically vegetarian based. And you can see here that at least in the top half of the table, also between 1 and, let's say, 6, you can see a number of things in vegetarian food with very similar iron content to meats. So what is really the difference? The difference is that the iron in vegetarian food is different iron. There's 2 types of irons. There's heme iron coming from meats, and there is non-heme iron coming from vegetarian vegetables, basically. And they have 2 different receptor pathways for uptake into the body. And these 2 different receptor pathways have a 3-fold difference in efficiency. So the same amount of iron in absolute terms in the nutrition gets you 3 times more into the body when it comes from meat. This is the reason why maybe nutrition, tea drinking, vegetarian food is associated with more iron deficiency, but again, there may also be other reasons. And then, of course, you want to discuss treatments. Very theoretically, you can discuss transfusions, but transfusions have many infection problems and actually also quite a high cost to society. Then you may have erythropoietin, you may have it alone or in combination with other things, and you may have different irons, and we would like to discuss some of this. Now, when you discuss in heart failure patients treatment of anemia using erythropoietin or double protein alpha, there was a big trial called the RED-HF trial. This trial was done in more than 2,200 patients, 1-to-1 randomization, running for several years, treating anemic patients who were supposed to be without iron deficiency. Iron deficiency was defined with a TSAT of 15%. Now, I gave you in my definition already a 20% cut point, so maybe some of these patients were included with too low transferrin saturation, but of course the knowledge about iron definitions has changed over time. So when this trial was done, it was shown very clearly with EPO, with double protein alpha, you can correct hemoglobin values. An increase of about 2 grams per deciliter was found. But as you can see on the right-hand side, there was no benefit for events, 0 benefit. There's overall no benefit for symptoms and quality of life and no benefit for events, despite an increase in hemoglobin of 2.0 gram per deciliter on average. Keep that in mind. There was, of course, an iron problem. For instance, and if you look into the publication, it is published that the median ferritin was 102. A median ferritin of 102 basically means that almost 50% of patients had a ferritin less than 100. And that in itself is a definition for iron deficiency. So in other words, this trial was full of patients with iron deficiency, where really you then need higher doses of EPO or double protein alpha to basically get an effect. And of course, this kind of treatment causes iron deficiency. So when you have at baseline 50%, maybe during the study, 60 or 70% of patients had iron deficiency. So maybe this study would have had a chance with a real combination treatment of double protein alpha and IV iron, but that it didn't happen. So when you then want to use directly intravenous iron, you may ask yourself, what is actually intravenous iron? Intravenous iron is always a sugar shell with iron bound in it. And depending on the sugar, you can bind more or less iron. In modern irons that are now available, it's about 1,000 milligram that you can have in a solution that you can basically infuse over relatively short periods of time. For ferric carboxymaltose, 1,000 milligram can be given in 30 minutes as a short infusion. In our phase 2 studies, we used iron sucrose, which is given in up to 200 milligrams of dosing over 15 minutes. So 200 milligrams you can give once a day, and then you give it every week, so you correct iron deficiency over 1 month. With the new version, you give the same amount of iron on 1 day. And with oral iron, you need 6 months. So this is kind of showing you the evolution of making iron treatment more efficient. One word of caution, anaphylactic reactions, they do happen with dextran irons every now and then. Try to avoid dextran irons. It's not worth it to have life-threatening situations. Now, when you start thinking about treating patients with intravenous iron, there is a discussion of how often do you give this, how high should you go with the ferritin, or when to stop. There was one trial investigating 2 different targets for ferritin using ferric carboxymaltose. One target was in the 400 to 600 range of ferritin values, and one was in the 100 to 200. And then with oral iron, it's of course different. Now, in this 3-arm study in patients with chronic kidney disease, it was found in the end that the number of events of interest, and in this study basically there was an interest to really check for endpoints that were hospitalization, death, and also serious other kind of effects. And this event rate was more than 50% increased in patients having not the high target. The high target had the lowest event rate. So that gives us good certainty for what we are doing in heart failure being the correct target. So what are we doing in heart failure? Well, the first phase 3 study we did was the FAHF trial. And because we previously had used iron sucrose and now wanted to switch to a better product, and we wanted to do a double-blind study, we had to consider ferric carboxymaltose. Think about doing a double-blind study with a dark brown fluid. It's rather complicated. You cannot give the iron without knowing that you give the iron. The real placebo in this case is sodium chloride solution is translucent, whereas the iron is dark brown to black. Now, what you need to do is you need to simplify the process. If you give an infusion, making double-blind infusions is generally difficult. So in the first study, we did actually injections. And the good thing is that 200 milligram with iron sucrose is an infusion, but with ferric carboxymaltose is actually a push injection of 3 to 5 seconds. So that enabled us to really do a double-blind. We used the iron definitions for deficiency as I gave before. We used basically patients with systolic heart failure that were symptomatic, and we had a stopping rule of ferritin above 800, or if ferritin was above 500 plus a T-set above 50, we had also a stopping. We had blinded and unblinded staff members, half a year of follow-up, 2-to-1 randomization, main endpoint were symptomatic. This was an international trial done in a number of countries, and the patients looked like this, 304 versus 155 patients, 68 years old, half of them women, and 11.9 was the average hemoglobin value for these patients. So half the patients had anemia, half the patients did not have anemia. When we do our intravenous iron therapy, the average dose we give in half a year is about 2,000 milligram. There is always a correction phase, on average 1,500 milligram, and then we give some more iron in patients that continue to be iron deficient, approximately 500 to 1,000 milligram for every further half a year. When we do this in our trial, we found that the patient global assessment was significantly improved. Patient global assessment is a questionnaire, a one-question questionnaire, where you ask the patient, how do you feel compared to the beginning? And basically 50% versus 27% said much or moderately improved when they were on iron compared to placebo. Highly significant improvement. And with New York Heart Class, you know, as a measure of symptoms in these patients, 47% versus 30% were at 24 weeks were in class 1 and 2. Now, so far so good. But the surprise was that all these significant benefits were already present at 4 weeks. And the good news is we now know that these benefits are there after 1 to 2 weeks. So if you give Ferinject to patients, you will see that many of these patients respond rather fast, which is very good for the interaction with the patient because they see the benefit of having done the treatment. 6-minute walk test also improved, and quality of life also improved. Now, the treatment was so homogeneously positive that we did not find any subgroup that didn't benefit, and that's the point of this slide. You will see a very homogeneous arrangement, whether the patient were more obese or not, men versus women, whether they were older or not, or whether they maybe had ischemic etiology or diabetic etiology or not, the patients had a similar benefit. There was one subgroup of patients that was of particular research medical interest, and this is the patients with or without anemia. That was pre-specified, and that was actually stratified in the randomization to allow for this comparison to be really valid. As you can see here overall, there is no significant difference for the primary endpoints for the comparison of patients with anemia or not at baseline. The interesting point is that the patients who had anemia at baseline had a change of 0.9 gram per deciliter compared to the placebo patients, whereas the patients who did not have any anemia at baseline, they had no difference in their hemoglobin values. So you got a benefit out of the iron treatment, but if you didn't have anemia to begin with, the benefit was there regardless of any change in hemoglobin. And if you had anemia, well, the hemoglobin change was only 0.9. It was much higher with EPO, or double protein alpha, but actually that didn't help you. But here, with a small change in hemoglobin for the anemics, and with no change in hemoglobin for the non-anemics, you got the full benefit out of iron treatment in iron deficiency. That proves that iron deficiency is the target, not anemia. That proves for the follow-up of patients treated with intravenous iron, you do not need hemoglobin. You need the assessment of iron deficiency to know whether you need to continue, whether you need to still correct iron deficiency, but you do not need hemoglobin. Now, when I say to you that this treatment is making organs perform better, one important organ is, of course, the kidneys, and they improved in these patients. So these patients had an improvement in kidney function after ferric carboxymaltose treatment. And again, I would like to say this is because also kidney function is an energy-intensive process, and it needs more energy in the cells of the kidneys. And with treating iron deficiency, you enable this. You need to talk about safety and all these kind of things. And this is some information about rates of events. And in this first study, we got a first hint that the iron treatment for these patients does reduce events, but it didn't reach any significant. This was done for safety and really should be taken with a grain of salt in this first study. But the rates, if you look at the numbers in brackets, because this is a 2-to-1 randomization, the absolute numbers may be misleading. The rates are always lower in the iron treated group. When you come to things that were increased, there's two things to say. Number one, gastrointestinal side effects, 17% versus 7% in the placebo group, somewhat increased, but we did not see this again in the CONFIRM-HF trial. And then we had 6 injection site reactions out of 2,000 injections. This is something that happens, of course, when you give sometimes iron, but you need to do better control of quality, and then this is not a problem. So here we have the first evidence that you can improve symptoms and quality of life and also performance of patients by 6-minute walk test when you give intravenous iron to iron deficiency patients. But only half a year, but not using the iron in the way we are aiming to use it today with 500 or 1,000 milligram kind of applications, but only using 200 milligram applications. So a new study was needed to really get rid of this problem of having not sufficient information to guide how to treat actually patients in reality. The CONFIRM-HF trial led by Piotr Ponitkowski, I was involved as well, published last year in the European Heart Journal, basically closed all these gaps. 1 year of follow-up, 1-to-1 randomization, and now patients were included with a hemoglobin up to 15, so really non-anemic patients were included as well. Primary endpoint, 6-minute walk test, and using dosing of up to 2,000 milligram in the correction phase. The patients had a mean age of 69 to begin with. The hemoglobin at the beginning was 12.4, and the ferritin was in quite a number of patients below 100, 90% overall. Also in this study, primary endpoint highly significantly beneficial, 6-minute walk test, 33-meter improved. This is a clear indication that the patients had better performance when they received the intravenous iron. Again, no subgroup that didn't work, which is an important thing. There is no patient that doesn't benefit as long as they have iron deficiency. If you look then over the full 12 months period, looking at patient global assessment, you can see the effect remained significant to the end. For New York Heart Class, the same 6-minute walk test, the effect became even bigger towards the end of the study, almost like 40 meters. The fatigue score was improved, and also Kansas City quality of life questionnaire was significant also at 12 months. Now, this study had a second function. Besides all these endpoints, it also started to, for the first time, look into events and looked into secondary endpoint of hospitalization for heart failure. And that pre-specified endpoint was significantly improved, and the event number went down by 61%, reaching significance. 10 versus 32 hospitalization observed. Of course, small numbers, but a first hint that everything goes in the right direction, and this is the Kaplan-Meier curve furthest. Now, of course, 42 events. Does that really tell us, even if they're distributed like 10 to 32, doesn't tell us enough about events, death, hospitalization. So what we did is, and this is now submitted for publication, we did a meta-analysis of all available clinical trial data on ferric carboxymaltose from 4 different trials, put them all together, and have then 839 patients analyzing them for these events. And then you get suddenly a number of significant results. Everything in blue is significant. Basically, we first looked into recurrent events. Recurrent events means that you look not only for the first hospitalization, but also the second and the third one. And you also, of course, consider death, because when you die, you cannot have more hospitalization because you're dead. So you need to analyze the rate of hospitalization relative to the survival time of the patient. And when you look into this, you will see that there is a 40 to 50% reduction in event rates. Highly significant, very encouraging in this study. We did a sensitivity analysis with the classical time to first event. Several things significant, others with a trend, but the power of this analysis is less, because here we have 114 events, for instance, if you look into cardiovascular hospitalization and cardiovascular death, whereas with recurrent events here you have more than 160 such events. So this makes a difference for the statistical power of such a study. 50 extra events gives you more power in the recurrent events. So coming towards the end and really trying to tell you where are we going? I would like to say we have done 2 excellent, very positive studies, the CONFIRM-HF trial and the FAIR-HF trial, and we have done now a meta-analysis. There is more trials that go on, and these trials basically include the ICHF and the EFFECT-HF trial. They will report within the next 12 months regarding exercise capacity with regards to cardiac function of patients. In the US, there's a trial ongoing of oral iron versus IV iron. It's the iron out study. I suspect it will also report within the next 12 months. And there are some more studies, and this I would like to highlight. One trial is the FAIR-HFpEF trial, and we also hope to have at least 1 or 2 centers in India participating in this study to investigate the effect of intravenous iron versus placebo in patients with preserved ejection fraction heart failure. And we will do a morbidity mortality trial. It's entitled FAIR-HF2. We have from the German government some grant money for this. 1,200 patients at least will be recruited, followed for 2 to 2.5 years, and we hope to document what we have seen in the meta-analysis also prospectively in a trial. And again, it would be great if we could collaborate on this. So lastly, it leads me to say, what do the current guidelines say? Now, the current guidelines, they are almost 4 years old. The current guidelines were written, and I had the chance to participate. They were written basically on the basis only of the FAIR-HF trial. So in the past, it was said, yes, assessing iron deficiency is part of the management for laboratory assessment in symptomatic patients. Ferritin and transferrin saturation should be assessed. Anemia should also be assessed, but that's like a separate thing. And then there was a statement that you may consider giving ferric carboxymaltose in these patients simply because there was this strong evidence of benefit from the FAIR-HF trial. Now, you know, of course, how the rules for guidelines are. First of all, we don't know yet the results of the new guidelines. They will come out in May. But the rules are that basically they are specified here. Maybe I would say that the weight of evidence is now clearly in favor of using ferric carboxymaltose for patients with iron deficiency, and maybe it could be a 2A should be considered type of indication, but we will see. And of course, if you look at the level of evidence, I would suspect that this is rather positive because we have several trials supporting this idea. Now, I would like to conclude what you really should take home. First of all, how to diagnose iron deficiency. Iron deficiency is present when you have a ferritin less than 100 in any chronic illness patient, but particularly in heart failure. We have now strong evidence for this. If you use this definition and then treat the patient, you get the benefit. If you have a ferritin between 100 and 300, an additional transferrin saturation assessment of less than 20%. Every patient with heart failure and iron deficiency gets 1,000 milligram. That's how we did it in the trials. That's how we did it. We'll do it also in future trials. If the patient has a body weight above 70 kilogram, add another 500 milligram. If the patient has a hemoglobin less than 10, add another 500 milligram. So you may have 1,000, 1,500, or 2,000 milligram of dosing. And we have used these kind of dosings in our trials. Now, when you then have done this correction, you do not need to give the patient any other treatment as a follow-up for quite a while, because they have definitely enough iron on board. So no need to switch then after the correction with ferric carboxymaltose, no need to switch then to oral iron. It's not needed. After 4 months, we assess the iron deficiency again. If there is iron deficiency, we just give 500 milligram and then leave the patient alone again for the next 4 months. We do not want the compliance risk and we do not want the side effects of oral iron, so we stick with the intravenous iron. 3 times a year we check for iron deficiency. If there is some, 500 milligram. If there is none, that's fine. On average, we have then maybe over the next year or so, if you have like 3 assessments in 12 months, maybe 1 or 2 will show up positive in these patients. So that you give in total in the order of 2,500 milligram over 1 year. And we will see in our studies that will take longer how this then is in the 2nd and 3rd year. I would like to also really take you home the message that the action of iron is not so much related to hemoglobin. There may be an aspect of that in a small number of patients, particularly when they have severe anemia. But when they have mild anemia or no anemia, the effect comes from the iron itself on the tissue level. And then lastly, maybe some of you have a chance to also come to us, to Europe, to Florence in particular, on the 21st of May with the opening of the Heart Failure Association of Europe Congress. The new guidelines will be shown and will be discussed for 4 days in this Congress. And lastly, I mentioned the fact that we need more research. And if you have a chance of having some of this research written up, we have now an open access journal, the first open access journal for heart failure specifically. It's called ESC Heart Failure. And you have a very good chance of publishing there because you can talk to me. I'm the editor-in-chief. So let me finish by saying again, this is how we do the IV iron treatment, and I thank you for your attention.